Okay. Okay. Thank you guys for joining on such a short notice. I will talk about conduction system pacing, a topic that we did not discuss in the past. Okay, these are my platforms, and please feel free to check them out. Okay, so when we pace a patient, routinely the implant include right ventricular pacing, whether epicardial or endocardial. Okay. Epicardial meaning outside the surface of the heart, endocardial transvenously through the veins into the heart. And usually with pediatrics, the indication is complete heart block, and hence the patient would require pacing throughout his life. And he's a young patient, so we are talking many, many years of pacing. Okay. And traditionally, with RV pacing, there is a percent, roughly 20% of patients will develop ventricular dysfunction or pacemaker-induced cardiomyopathy, especially if the percent of ventricular pacing is above 40%, okay, which is many of our patients, okay? And our numbers locally are around the same, okay? So, and of course, the RV pacing specifically has been associated with mortality in both non-congenital heart disease patients and congenital heart disease patients. So, there are definitely disadvantages. So this is an X-ray. You see my pointer, right? So this is an X-ray of uh, epicardial bipolar lead on the lower surface of the right ventricle, epicardially, of course. And then this is a transvenous pacemaker through the SVC into the apex of the right ventricle. So these are very typical locations into the RV endocardially, which is usually RV apex, epicardially, usually at the diaphragmatic surface of the right ventricle. Okay. Anyways, so because of such, cardiomyopathy incidence and mortality risk, people want obviously to lower that risk. So how do we reduce pacemaker-induced cardiomyopathy and hence mortality? You want to first of all avoid percent ventricular pacing. So either by lowering your, rate, or you limit sinus tracking, sinus tracking. So eventually you want to just decrease the amount of time that the ventricle is being paced, okay? But you may not be able to do that all the time. Otherwise, you want to try to implant the lead in a different spot that is more physiologic, okay? So with epicardial placement, the apex of the systemic ventricle is usually a good location to engage the systemic, His-Purkinje system. And with endocardially, of course, you want to try to engage the endocardial system, which is called in broad conduction system pacing, and I will talk about that in a minute. So typically here at our center, at least, if the patient is less than 20 kg, epicardial approach is preferred. If the patient, sorry, is above 20 kg, endocardial approach is possible. Okay, and you can use single ventricular lead to try to engage the His-Purkinje system. So this is an X-ray of a patient who underwent, a baby with complete heart block, congenital complete heart block, who underwent apical left ventricular pacing, epicardially, of course, and this has been more routine since the past 2 to 3 years. Okay. Otherwise, you could try to you can implant two leads on the ventricles, and this is called biventricular pacing. If you have a biventricular, patient, if you have a single ventricle patient, you can implant two ventricular leads on that same, single ventricle, which is called multi-site pacing. Either way, you're trying to pace the ventricles from both sides, and hence synchrony might be better. Okay. And then when you use two ventricular leads, this is called cardiac resynchronization therapy. And if the approach is epicardial, it's epicardial CRT. If the approach is endocardial, it's endocardial CRT. So this is where this is the definition of CRT. You're using two ventricular reeds, okay? Cardiac resynchronization therapy, okay? Um, and this is an example of a patient who has left ventricular lead, right ventricular lead, and obviously as well right atrial lead. Okay, so CRT epicardial system for a patient with this patient has a complex transposition patient VSD and had complete heart block and then developed pacemaker-induced cardiomyopathy, and then we upgraded the system into epicardial CRT in order for an attempt to salvage the ventricular function. Okay. Anyways, okay. So what about I'll talk about conduction system pacing in a second, but in a broad terms, cardiac physiologic pacing is divided into cardiac resynchronization therapy, which, like we said, you use two leads on the ventricles, whether epicardially or endocardially. And obviously, endocardial option is not always possible if the patient is small in size, for example, or if there's congenital venous anomalies that preclude you from accessing the ventricle, or if there is, for example, coronary sinus anomalies and so forth. Okay. In addition, if you have, like tricuspid valve anomalies or abnormalities or regurgitation, if you have intracardiac shunting, you cannot also do endocardial approach, because obviously if you are crossing the valve and the valve is regurgitant, crossing the valve with a lead, the regurgitation might worsen, right? If there is a shunting between ventricles and you're having a lead into the a ventricle, then there's a risk of systemic emboli. Okay, so anyways, so there is endocardial contraindications. So this is why we often rely on often try to do epicardial or often we are limited to epicardial options. Sorry, unless unless endocardially is possible. Okay, so this is a cartoon showing transvenous sorry, transvenous implant. There is a right atrial lead, right ventricular lead, and there's a lead that goes across the coronary sinus into epicardial branches of the coronary sinus that can pace the left ventricle. Okay, so now you have left ventricular lead and right ventricular lead, and this is called cardiac resynchronization therapy. This is transvenous option. Okay, I already showed you an epicardial option in the past slide, if you remember. This is an epicardial option on this image, and this is endocardial option, cardiac resynchronization therapy. So what about conduction system pacing, which is more recently applied to our patients? This is when you use a single ventricle and endocardially only in order, and with this single ventricle, you are engaging the His-Purkinje system. Either you're directly pacing the His bundle, or more recently, you're pacing the left bundle of the conduction system. Okay, does that make sense so far, guys? So you hear the terms often cardiac resynchronization therapy, and now you will hear more and more often left bundle branch area pacing, which is a form of conduction system pacing. Okay, and those two terms are broadly called cardiac physiologic pacing. Understood, guys? Am I too fast?
It's okay.
Yes, sir.
And remember, there's epicardial options, endocardial options. This is why when someone calls me, a patient has a device, all these information are very important. Okay, is it epicardial? Is it endocardial? Is it CRT? Is it CSP? Is it left bundle branch area pacing? Is it dual chamber? Is it these are very important pieces of information that you need to share with us. Okay. Anyways, so with when you are doing conduction system pacing, which, like we said, the only option is endocardially and hence transvenously, usually the patient should be above 20 kg. Okay. And with his bundle pacing, it's limited because it's challenging, because the his bundle is a small piece of tissue. And so you have to implant the lead directly into the His bundle. And besides the challenge in, in engaging the His bundle directly, it usually requires high thresholds, and the lead dislodgement is common. Okay, so this is not commonly done, worldwide. And in Kuwait, we don't do it. Okay, but more recently in 2017, left bundle branch area pacing had been described. Okay, so what is left bundle branch area pacing? You insert the ventricle deep into the septum, in order to engage the left side of the septum. Okay, so this technique provides excellent thresholds. Usually the thresholds are low, and the lead is very stable because it's embedded in the ventricular septum, and the R waves are large. Limitations obviously can perforate into the left ventricle, and then there is usually the lead is under stress, and I'll show you why in a second. And then people wondering whether it's possible to extract them after, many, many years. It's a recent advancement, so we don't have long-term data. Okay, so that's an example of a left bundle pacing patient in our patients. This is a patient with congenital complete heart block, and I'll present this patient in part 2 of this lecture. So you have obviously endocardial. The device is in the left pectoral area. So there is this right atrium lead, and then this other lead is crossing the tricuspid valve and then going, perforating this, not perforating, sorry, embedded deep into the septum in order to engage the left bundle branch of the conduction system. Okay, and this is another example of a patient of ours as well who underwent right-sided implant because there was left superior vena cava. So when you go to the left side, the wire would go this way. Okay, so then it's difficult to go to the SVCCS, and then you have to turn around and you go to the ventricles. Difficult. Okay, so it's possible, but more difficult, especially if you're planning to engage the left bundle, part of the conduction system. So this patient, we planned to perform conduction system pacing, but then we realized in the cath lab there is left SVC, which by the way was not very well documented in our notes. Luckily, we only insert a wire. We did not open. This is why I usually try not to open, just insert wires and see the course. And then we switched to the right side implant, and then we attempted to engage the left side of the septum, and we did. We were luckily successful to engage the left side of the septum. Okay, anyway, so these are two recent patients that we did in our center. Anyways, so in terms of data for CRT, because it has been around for more years, if you have a systemic ventricle that is less than 45%, or you have symptomatic heart failure, or there's electrical dysynchrony significant on echo, there is definitely survival benefits and improvement in ejection fraction when you perform CRT for such patients. Okay, so there is clearly benefits from applying CRT to such patients. But with conduction system pacing, the data is more recent. In adults, it has been shown to be non-inferior to CRT. Okay, more recently there is less. So death was lower actually in CSP compared to CRT. So it's actually a little bit better even. Okay, and for pediatric data, has been reports of improvement in pacemaker-induced cardiomyopathy with CSP in both congenital heart disease patients and non-congenital heart disease patients. It usually results in narrower QRS, improved synchrony, improved strain patterns, and then there has been recent data comparing CSP to CRT in congenital heart disease patients, specifically with biventricular physiology, systemic left ventricle. There was similar improvements in left ventricular ejection fraction and complication rates, but there was better QRS or low or improved QRS duration or narrower QRS with CSP pacing. Anyway, so the data is very promising, okay, in both pediatrics and adults. But remember with CSP pacing, there's less leads. So with CRT, there's two ventricular leads. With CSP, systems, there's one ventricular lead. So there's less, infection risk, less complications from extraction, should there be an extraction. Make sense, guys? So overall, I think CSP is gonna be the main, approach for cardiomyopathy patients in the long run. Okay, guys? Understood? Unless there's specific contraindication. Okay? Questions? Guys, questions? Too complicated ولا easy?
ده ايه يا دكتور محمد؟
Okay, حلو. Abbas. Okay. Okay. So um okay. So okay, so this is data in pediatrics comparing left bundle branch area pacing with our traditional right ventricular pacing, and as you can see, the for example, the ventricular dilation is less with left bundle branch area pacing, left ventricular ejection fraction is better, and so forth. Okay, so there's clear data of clear, good data with left bundle branch area pacing. Furthermore, you can, sometimes you can do hybrid, for example, epi, endo, CRT systems. There are complicated systems that you can do, but also you can do combined other stuff. For example, you can place one lead into the HIS and another lead through the CS into the left ventricle. This is called HIS optimized CRT, or you can implant one lead. So this is HIS, so HIS, hot CRT or HIS optimized CRT. So there's one lead into the HIS, which we don't do again, and another lead across the CS into the left ventricle. Okay, so this is called hot CRT, or LOT CRT, meaning one lead across the tricuspid valve into the left bundle, another lead across the CS into the left ventricle. So this is called LOT CRT. So this is another newer forms of CRT. Instead of applying the second lead into the RV apex, left bundle lead plus CS epicardial lead is probably even better. Okay. So anyway, so there are different combinations that now with recent advancements, there are a couple of more options that we can try for our patients. Okay. Okay. So presumably LOT CRT or HIS or hot CRT is better than regular CRT. Okay. Okay. And then, like we said, there's other endo-epi combinations that are possible. For example, you can implant transvenously, left bundle lead and epicardially, left ventricle lead, and so forth. Okay. Anyways, so like we said, you can, technically, you can, you can paste the HIS bundle, you can paste the right bundle, you can paste the left bundle, you can paste the left, ventricular septum, and you can paste even the fascicles. Okay, so there are many, many different areas that you could try to attempt to paste. Okay, and collectively, left bundle branch area pacing is when you pace the left bundle branch or the left LV, septal septum, or left fascicular bundle. Okay. Okay. Um, and there are specific ECG differences between both that we will not go into. Okay. Okay. So in 2023, because of the recent advancements in conduction system pacing, previously conduction system pacing has not been in the guidelines. Okay. But in 2023, it started to appear in the guidelines. Okay. So this is for, I'm trying to get rid of this. So this is for pediatric patients with complete AV block needing ventricular pacing. So if you have a patient with complete heart block needs ventricular pacing, and there's myocardial dysfunction, and he has an existing like RV lead, then like he has pacemaker-induced cardiomyopathy, you can add another lead to the right ventricle and you switch the patient to CRT system. Okay, easy. This is what we routinely do. If there's no existing lead, again, patient has heart block and dysfunction, but no leads, you can do either CRT or CSP. Okay, either way. Okay. And if the patient has heart block, needs pacing, and has transvenous, it's possibly to do it transvenously, um, but without heart dysfunction. Technically, you don't have to do CSP pacing, or you can still implant, do traditional implant, but um, you know, better than RV apex, better to target mid-septal RV, or inflow RV or outflow tract RV. Okay, better, apex, RV apex, which is the most traditional site, is the worst site. Okay. But honestly, nowadays, I think I will try my best to do CSP pacing even for such patients. Okay. And I think eventually it will show up on the guidelines. Okay. And then if it's an epicardial system that is indicated or is only possible, we tell our surgeon to do apical RV lead placement. Okay. Better than RV apical placement. Okay. Makes sense, guys? So this is our routine going forward. Okay. If you have a patient with congenital heart disease, so Mitwalli, this is for you mainly. If we have patients with congenital heart disease and the systemic LV, because Mitwalli is, by the way, our heart failure expert, and the systemic LV, and you have systemic LV, but the decreased function. Who's this? Mute. Okay. Okay. We investigate dysynchrony, we can do CRT pacing, of course. Okay, if you have a single ventricle, we will again try for apical pacing. Okay, if there's a heart failure, then CRT is usually, or multi-site pacing is the preferred choice. Okay, if you have systemic RV and symptomatic heart failure, again, you want to do CRT and so forth. Okay, so again, going forward, if I have patients with congenital heart disease with decreased function, we can always try to attempt CRT for such patients in order to try to improve their function, whether it's systemic RV or systemic LP. Okay. Okay. But in general, CRT is most beneficial with systemic LV, physiology. Okay. Um, okay. So Mitwalli, again, if you have patients that are having decreased function, especially with wide QRS, or with wide QRS, or there's pacemaker, pacing, we might need to create or do CRT for such patients. Okay. Anyways, and then also we need to, when we do echo for our patients, which we need to try to study the dysynchrony better. And in general, um, um, in general, we want to minimize dysynchrony as much as we can. Okay. So minimization of dysynchrony in single ventricle, especially, is increasingly recognized to be important. Okay. And then even if we have to implant a lead into systemic circulation in order to decrease dysynchrony, this might even be okay. Okay. And then more recently, but this is still not available, there is a new CRT system that is going to be hopefully in the market soon, called WISE CRT, in which there is a very small piece of small device that is implanted into the systemic ventricle that gets endothelialized, so there is no stroke risk. Okay, and no need for anticoagulation after a couple of weeks or a couple of months, and then you implant routinely the RV or whatever right-sided implant you're doing, and then that piece of device, when it senses the pacing on the other side, it will trigger contraction on the systemic ventricle through an ultrasound technology. Okay, so we can hopefully one day we'll do this for our patients. Again, we implant something very small on the systemic ventricle without the need for long-term anticoagulation because it gets endothelialized, but then you get CRT, you get biventricular pacing for such patients, okay? With a piece of, with a small device on the systemic ventricle, okay? Anyways, so our local experience, we did so far, I think, 3 cases of left bundle branch area pacing, 2 for pacemaker-induced cardiomyopathies. One was congenital complete heart block that we will actually discuss. And then second case was for post-operative complete AV block, VSD, and then initially had dual chamber implant, developed pacemaker-induced cardiomyopathy, and then had epicardial actual CRT, but then the epicardial lead got fractured, and then we did implant left bundle branch area pacing to that ventricle, to that patient, sorry, and then his function is good. Okay, and then we did a right-sided implant for an AVSD patient who had post-operative complete heart block and then had infected epicardial system, but normal function. We just did we did switch to transvenous, but we attempted for left bundle branch area pace. Okay, so we did 3 cases so far, and I think so far so good, except for one patient, there's a question mark, and I'll discuss that patient in a second. Okay, so obviously, if you have VSD patch, for example, it might be challenging to insert the lead into the septum because of the patch. So you have to go around the patch. So it might get complicated. But these patients, as you can see, at least this patient and this patient had patch and it went okay. Okay. And then because of such complications, we and other groups are trying to submit our data with other groups. For example, like in left bundle feasibility of left bundle branch area pacing in patients with surgical VSD, for example, and then in general in congenital heart disease patients, we're trying to submit our data to other groups so that we have larger data in pediatrics and congenital heart disease patients. Okay, so in conclusion, we talked about cardiac physiological pacing today, okay, which is defined as any form of cardiac pacing intended to restore or preserve the ventricular synchrony and ventricular contraction. Okay, so we said achieved through conduction system pacing, which we do by routinely or usually by attempting to pace the left bundle branch area, or through biventricular pacing, either through a coronary branch or epicardial LV pacing lead with a right-sided lead. This is called CRT system. Okay, and then we have to consider doing this in all of our patients with dysynchrony, especially if there's symptoms or decreased function, and the dysynchrony is non-mechanical, we think. Okay, questions, guys? So far, okay. Any questions? Okay, so now can I present like another? Sorry, I will present our case. Can I continue for 10 minutes, guys? Yeah.
Okay, no problem.
Yes, okay.
Sorry, I know it's prayer time. Okay, so just to make it more interesting, so this I want to show a case. So this is a patient who was born in 2011, 36 weeks gestation, delivered due to fetal bradycardia. Birth weight was 2.33 kg. So typically, our complete heart block patient, they are born young, small for gestational age. He was intubated due to severe respiratory distress syndrome. There's like white lungs, apparently severe. He was noted to have congenital complete heart block at birth, but I don't have the ECG available. And then mom has positive RON antibodies and positive ANA. And his brother also has congenital complete heart block and plus factor V Leiden deficiency. He had also actual stroke. Mom had history of stillbirth and consanguineous parents. Okay, so multiple important information in terms of family history. He was born with normal function and small ASD, but there's mild MR, mild AR. Okay, so he had complicated NICU course, okay? He was actually in the NICU for 4 months, okay? He had multiple issues, mainly cardiac. So besides so he was, on with incomplete heart block on isoprel, but normal blood pressures. He was actually on isoprel for 2 months. He was tachypnic a little bit. He has hepatosplenomegaly, but in general, he had overall very good hemodynamics, okay? He at some point had transient decrease in function that I'm not sure why, and he was started on Lasix and aldactone, but then normal function normalized. Okay, and then also had a little bit of ventricular ectopy and was started on mexiletine. So very complicated initial course. Okay, this was before my time. Dr. Babu was the main, I think, cardiologist. Okay, he had severe respiratory distress syndrome and bronchopulmonary dysplasia, and he was intubated for like around 50 days or so. Okay. He also had, neonatal lupus, non-cardiac, like cardiac and other, manifestation of neonatal lupus, such as low platelets, and he had generalized rash as well. He received IVIG for that. He had neonatal cholestasis, and he had also Klebsiella septicemia. Okay. Um, but like I said, he was eventually discharged, and he had repeated good functions on echo, and he was discharged without pacemaker, by the way. Okay. So he had repeated normal echo uh, up until age of 1.5 years. He also had Holters, and last Holters he had an average heart rate of 47, and with max 69, minimum 38, junctional escape, no prolonged pauses otherwise. But then he was lost to follow for 10 years. Okay. And then he came back with nasal bleeding, came to clinic. We repeated the echo. Luckily, it was normal function. Okay. And this was his rest when he came back. This is, when he was older. He had obviously, clear, complete heart block ECG, right, guys? I will not explain it. صح? Straightforward.
Yes, yes.
If anyone has questions, please interrupt me. Let's تحون يعني, okay? Straightforward, صح? Okay. And I also had him do exercise stress test. And, during stress test, he had,
باشا وسط
funny,
المقاطعة.
he had like ABCs.
مفيش اي سي جي ظاهر عندنا على دي صورة حضرتك بس.
So, you don't see my slides, guys?
لا مش
No,
عارف.
let's see also.
You see or you don't see? Oh, sorry, you don't see?
لا أنا مش شايف سلايد.
Okay, wait. Sorry. Where is my slide? Okay. Share. Do you see it now?
Yes, clear.
Okay. So again, now you see my slides, صح? Did you see these slides or you did not see my slides here? You did not?
Yes. Before
Okay, sorry. So this is Nicky course. This is his output. I talked about all this, okay? So he has this is his resting ECG, okay? So sorry. So clear uh, clear clear complete heart block, صح? And then he had exercise, remained with complete heart block, of course, but he also had, funny PVCs with exercise. Okay. Okay. Questions about the ECGs, guys? Like monomorphic ectopy. That is okay. So then, he was not, he was still followed up, no intervention done until he had syncope in 2023. Okay. He was playing in Pakistan, actually in the heat, sweaty, very hot, probably dehydrated, and he fainted, I think, twice. Okay. Then he came to Kuwait, and mom told us this information. He had heart rate of 40 in clinic, and also, PVCs, like we said, like we saw on the stress test, slightly different. So, for example, this one is a little bit different than these. So not super monomorphic, but funny PVCs plus normal resting heart rate otherwise. Okay. Okay. So then, because of he started to become symptomatic, I recommended pacemaker implantation. Indeed, we did pacemaker implantation. It was actually initial. So we tried to do left bundle branch area pacing. This is the first pediatric case in Kuwait that we tried to do, but we failed during that time. We tried, we could not perforate the septum, or not perforate, we could not insert the lead deep into the septum. So it was more right ventricular septal pacing rather than left bundle branch area pacing. We paced him. We paced him at 70 beats per minute initially because we don't want to speed up the pacing rate because of concerns of cardiomyopathy, and we went gradually to we went relatively not super gradually, to be honest, like over 2 3 weeks, 3 weeks maybe. We had we programmed so that he has a normal heart rate. Okay, probably too aggressive from our side. So this is his uh, pacing ECG, paced ECG when he was paced at 70 beats per minute. And then this is him when he was when we slowly went up on his pacing rate. Okay. So as you can see in V1, okay, this is his pacing QRS, pace QRS. Sometimes you see the QRS change, and then it's like a right, like QR pattern, which is like a right bundle branch pattern. So this is the pattern that you want to see if when you pace the left side of the ventricle, you will get, RSR prime or SR in V1, like a right bundle branch morphology. And when you see this, this is a sign that you're engaging the left side of the ventricle. So when with unipolar pacing, we were able to intermittently engage the left side, but anyways, but definitely not continuously. Okay, so that's why it was a failed attempt. But 2 months afterwards, he started to have infection of his pocket. But in addition, we noted his function to decrease. Okay, so he actually had his function declined. Um, we tried to salvage the pocket, but usually we are not successful. And then we decreased the heart rate back, eventually to 60 beats per minute. There was some improvement in function, but remained not great. Okay. In addition, he started having, ventricular ectopy. So this is a interrogation from the device. The A stands for atrial, EGMs, and V stands for ventricular EGMs. And you can see there's many QRSs and less P waves. So this indicates there's ventricular tachycardia. Okay, so he had 2 episodes of ventricular tachycardia here. He also had an episode of atrial tachycardia. So, a little bit of arrhythmias, decreased function, infection, not great. System has to come out. So we explanted the device in February 2024. So this is roughly 5 months after implant. Okay, he was having ectopy. He actually had polymorphic or non-sustained, polymorphic VT during explantation. So we gave him lidocaine and then later mexiletine. But his ectopy resolved with mexiletine because we wanted to pace him again, and we wanted to reattempt left bundle pacing. We discharge him without pacemaker, because if you want to re-implant the pacemaker, you want to wait a couple of weeks before re-implanting if you want to use the same site. And mom did not want to stay for a couple of weeks in the hospitals. They have social difficulties. So he actually went home without pacing, um, but with close follow-up, repeated halters, no ectopy, no pauses. He remained asymptomatic and actually functioned back to normal. Okay. Following, guys? It's a complicated case, but following? Okay.
Yes. Yes.
Yes.
Okay. So, and then now his pocket healed. We reattempted left bundle branch area pacing, and this is the attempt. I had shown this X-ray before, and as you can see, there is RSR prime in V1 now consistently. Okay, so so you want to see this when you are engaging the left side, and as you can see, the QR is really narrow. I mean, you can measure it. It's around 100 and probably less than 100. Maybe 120 maximum. Okay, So 110, 120, which is great, almost like normal in terms of duration and with right bundle, okay? So you remember our patients, those with right bundle, usually they do very well, right? If you have left bundle branch block patients, they might not do very well, but right bundle branch ECG patients do very well. So again, typically when you pace the right ventricle, you will get a left bundle branch morphology, and hence they might not do great. If you pace the left ventricle, you'll get right bundle branch morphology, and hence they will do better. Okay, so this is right bundle branch block morphology, which is a sign that we are actually pacing the left bundle. Okay, so it's a good sign. Okay, understood, guys? In addition, the QRS is nice and narrow. Okay, understood, guys?
Yes, yes.
Okay. Anyways, we started slow at 70 beats per minute. Unipolar was better than bipolar in the cath lab. But unfortunately, he was programmed bipolar. This is probably my fault. But June 26th, this is like roughly 1 month after implant, VVI 80, normal function. And then in August, we increased the rate to 100. I don't think we did an echo. And then in April, so he felt great, and he actually lost the follow-up again for, I don't know, like now, 8 months. Okay. So he came back, but then function was slightly less at 40%, you know. So what we decreased his rate back to 50. Okay. But we switched his programming from bipolar to unipolar, and we gave him some heart failure meds. Okay, so and then unfortunately he felt great regardless, and then he went to Pakistan, and he's coming back in September. So this is his bipolar, pacing, and as you can see, there's no nice RSR prime in V1. So, maybe what happened is in the cath lab, we had nice RSR prime, but after he went home, probably there's micro movement of the catheter, such that we are not having RSR prime in V1 with bipolar pacing, and this micro movement might result in something called a nodal capture. So this is complicated now, but I'll just explain it in a second. And this is, when we switch to unipolar, you see the difference? You see RSR prime in V1, right? In bipolar setting, there's no RSR prime, okay? Clear, guys? Clear? Both have narrow QRS. So, so this is bipolar setup, no RSR prime in V1, or there's a little bit of RSR prime, but not as good. The QRS duration is probably, I don't know, you see, but probably 110, 120, right? And then in unipolar pacing, QRS duration is probably the same, but there's a nice RSR prime in V1. Okay. So because of this finding, I think unipolar pacing was a better option for him. In anyways, regardless, so what might have happened with this patient, yes, you are engaging the left bundle, okay? You're engaging the left bundle, but because the catheter moved a little bit, you're also engaging the right bundle, okay? And then you might engage the right bundle before the left bundle, and then you'll get, normally the left bundle, activates the septum first, and then right bundle gets activated. But now, if you're engaging the right bundle before the left bundle, it's not as normal as when you engage the left bundle before the right bundle. Okay, so this is called a nodal capture, and this in some patients that are very, very sensitive might result in not improvement in function or a little bit of decline in function. Okay, so so he'll come back from Pakistan in September. Hopefully his function will normalize because we did two intervention. We did unipolar, we switched to unipolar pacing, plus we lowered his heart rate. Okay, now he's safe. He will not get prolonged pauses, and hopefully his function will improve. Plus, hopefully, and then when he comes back, we'll slowly go up on pacemaker and see whether his function improves or remains good or not good. I mean, if his function declines again, there's nothing else we can do except maybe we'll try to pace the his bundle, which I don't have experience with, and then otherwise we just keep him backup pacing so that he's safe and he doesn't get syncope. Okay. Anyway, so this is in general, conduction system pacing that includes, plus cardiac rejuvenation therapy patient. Okay, so that's a nice case, challenging case, but we learned a lot from this case, and hopefully, I think eventually he'll be fine. It's just, challenges that are, that we face in some, with our patient that we learn from. Okay, questions, guys. How many minutes did we نشوف؟
دكتور محمد معلش، هو ليه لما حضرتك قلت كانت غلطتنا اللي احنا خليناها باي بولر وما كملناش يوني بولر؟